Good afternoon, everybody, and thank you, Sages and Dr. User, for the invitation to speak today. Happy to be here. All right, so disclaimer, consultant Boston Scientific and honorariums from Medtronic for some lectures. So objectives today is to discuss the need for PEG in altered anatomy, and again, look at some of the most commonly altered anatomy situations. So for the most part, this is obviously kind of difficult kind of titling of this presentation, because a lot of times the stomach, when you have altered anatomy, sometimes you don't have access to a stomach, so it's no longer a PEG. But I think at the end of the talk, you can see that in many cases, you can still access the remnant stomach in some situations to provide nutrition and medications. But indications for PEG and altered anatomy are in situations where you have the same disease states, such as cancer, trauma, et cetera, in which these patients still need enteral access, but again, you simply don't have easy access to the stomach itself. And the primary access for treatment are, again, also seen in post-operative complications such as refractory anastomotic strictures, chronic nausea, distension, dehydration, failure to thrive, biliary access. So again, a lot of times, in these situations, you're simply trying to provide access to these patients for the standard indications for PEGs, but then also you can have some issues in the post-operative state, which is related to the altered anatomy. Again, nothing really changes in the pre-procedural workup in terms of looking at the basic, absolute and relative contraindications. Nothing should change. It doesn't matter what previous surgery you have. You still want to see if there's a true indication for a PEG. But a couple other things I've thrown in there, which I think is important. If they've had any other previous surgery, obviously it's important to get the preoperative note. That'll give you a nice roadmap to understand what they did to the anatomy, so you have a better idea before you go into the procedure. Examine the patient yourself. Obviously, look for any previous scars. That'll obviously be obvious indications that you need to get the operative note. And in some situations where you need to put a PEG in a difficult abdomen, preoperative imaging may be of significant benefit as well. You can tell where the stomach may be sitting, if there's any issues with the colon, if they had obviously like a Roux-en-Y bypass, if it was anterior or posterior to the colon as well. And if we look at the absolute contraindications, if we look down halfway below, it says altered anatomy, such as the bypass and previous gastric resections. For the most part, if we kind of build upon what we're talking about today, you're still going to have the ability to place PEGs in these patients, which we'll see in a moment here. So one of the most commonly altered anatomy, which most of us will probably encounter nowadays, is a Roux-en-Y gastric bypass. And again, sometimes there's a need to actually access that bypass stomach. And why? What are some of the reasons? So maybe for decompression, delivery of medications, and also access point to the biliary system as well. So what are your options in this situation? One of the more common one is a balloon-assisted endoscopy. So either some surgeon or majority of GIs will perform this procedure, in which you have placement, you go retrograde through the Roux limb back up into the remnant stomach, and at that point, once you're in the remnant stomach, you just perform a standard PEG, either introduce or pull method. The other option that you can also have to use is endoscopic assisted ultrasound. So in these situations, you're going to access the gastric pouch, you perform an EUS, and you gain access to the remnant stomach. And in that situation, again, you just follow the standard PEG placement that we were talking about earlier today, and you just go ahead and place your standard PEG. And again, these options are great. They allow access to the native stomach for obviously for enteral nutrition, and also for medications as well. So for successful U.S. assisted radiology, if you look at some of the literature, again, the volume for these cases is not high. In 2 studies, they looked at 11 patients, and they were successful in 10 out of the 11. So when you use EUS versus balloon-assisted enteroscopy, for the most part, I think balloon-assisted enteroscopy is probably the least, in a bypass patient, is probably the least invasive, because you're not creating that chronic fistula between the pouch and the remnant stomach. Balloon-assisted enteroscopy is going to obviously be less invasive than a lap-assisted or open G-tube placement, and then obviously an EUS would probably fall somewhere in between balloon-assisted and then an open or a laparoscopic G-tube placement. So again, these are some great options that you have for placement in the altered anatomy following a bypass. The other, one other thing to just keep in mind as well is that using EUS, certainly in a bypass situations, you can also leave a 2-lumen opposing stent, which can give you residual access later on if you need to go and access the biliary system again, or any other placement or replacement of the PEG. So just an option to keep in mind. I'm not going to get too much detail in this situation because I believe Dr. Marks is going to be following. He'll go over this in detail. But another option you have for bypass patients is looking at direct percutaneous endoscopic jejunostomy. Again, this is standard PEG placements. It's just more of understanding where you are in the anatomy. In a bypass patient, it's going to be placed in the root limb, which is going to be the jejunum. And the most difficult part of this case in particular is to kind of be assured that you have the root limb is going to be opposed to the anterior abdominal wall. So some options you have is to obviously utilize your standard methods, transillumination, one-to-one method, safe track method, but also you should also utilize radiology or fluoroscopy in the operating room. And a couple considerations to keep in mind when dealing with bypass patients is understanding, and again, this falls back to that first slide where you have to do just a little bit more due diligence, is understanding the anatomy following the reconstruction. So was the tube placed in a retrogastric or anterogastric fashion? Is it retrocolic or anticolic, which is probably the most important aspect of this, and it kind of makes sense. So if the root limb is in the anticolic position, obviously the risk of the colon being anterior to that root limb is going to be a lot less. So just some schematic here. Obviously in an anticolic, that root limb is going to be anterior to the colon, and then in the retrocolic, obviously you have the root limb posterior. So in these situations, again, reading the operative note or getting some additional imaging prior to placing the tube will give you a better roadmap to understand where exactly that root limb is sitting. So what if you have retrocolic root limb and you still want to try to place a PEG? One option you may have is to consider simultaneous colonoscopy and fluoroscopy in the OR when placing this PEG, and I'll have a little bit more details on that in a moment, but something to keep in mind. Again, I'm not going to go too much detail about this, but this is just a placement of the PEG through the jejunum, or PEG I should say. So other options to keep in mind as well is if you're going to be placing a feeding tube into jejunum in a bypass patient, some things to consider is the use of glucagon, which can decrease motility, gives you a little bit more steady or calm bowel when you're trying to do your safe tract or your one-to-one motion. If you feel that you have a nice safe track to place your feeding tube, place the T anchors, some gastrointestinal T anchors as well, so you can stabilize that bowel to the anterior abdominal wall and then kind of complete the placement of the feeding tube under a little bit less distress or rushing to get it done because you don't want to lose your access site. Fluoroscopy is obviously a great tool, and then that preoperative imaging or concurrent imaging as well. So just looking at some of the data, how often is fluoroscopy used? Now, for most of us, fluoroscopy is, it's easily available in the OR. As long as we just ask for in advance, it usually is pretty easy to get. But if we look at the data, it's only really being utilized in less than 1% of cases. So I think that's probably, could be an underutilization. If there is situations where you're not really sure if you have a nice safe track, it may be a good option to use. Now this is one situation where this was contributed by Dr. Huza, but this is a PEG and altered anatomy. This is a patient who had a chronic fistula in which he utilized the fistula opening. He scoped through the fistula. He ensured that he was going downstream using radiology. So here the feet are at the 12 o'clock. He's already put the scope in. They've gotten good access, and he simply pulls the double loop, the guide wire out, and he's going to go ahead and complete the PEG in standard fashion. But again, he utilized fluoroscopy prior to placing the introducer catheter, and simply to ensure that he was going distal to the fistula opening. Nice job. So PEG and altered anatomy again, and I mentioned this previously, but don't forget you can also utilize CT scan concurrently or do a rendezvous CT PEG. So what is that? So if you have a complicated anatomy, you can take the patient to the radiology suite or interventional suite. You can do a CT scan. You can ensure that you have direct access to the stomach. You can place radiopaque markers at the level of the stomach. And if you have an endoscopy team available at that same time, you could go in and complete the endoscopy at that time, or you can leave the access to the stomach, bring him to the endo suite, and do a rendezvous where you just place a peg in the endo suite. This is just the steps that we just mentioned. So A is just seeing that the stomach is in the left upper quadrant. You do a scalp CT scan, you see some dilated anatomy. You can do an on-table EGD in the CAT scan. Again, put the radiopaque marker and then complete the peg in the CT scanner, or you can take them to the endo suite and complete it there. All right. Colonoscopy assisted peg, we just mentioned. I'm going to skip that for the sake of time, but this is the room setup that we use. And just one last thing, again, this is, again, you can see here, this is colonoscopy-assisted pegs. You can see that the white marker is demonstrating the use of the colonoscope to move the colon away from the axis to the stomach. The red arrow is demonstrating the stomach itself. So another option that you also have is use the colonoscopy in the operating room. And just some other altered anatomy, just some fun pictures of some patients put pegs in, obviously LVAD. And again, use fluoroscopy, just get the scope into the stomach, take your fluoro, ensure that you have a nice open track, and just complete your peg. And then finally, use gastrointestinal anchors. When you do have success in placing your feeding access, put anchors in there. It'll just give you a little bit, if the peg gets pulled out, you have the ability to kind of go back in and rescue that peg as well. So thank you for your time. Appreciate it. Thank you.